All right. So we are having some technical difficulties today. All right. Um, okay. So hopefully you guys see this. We're gonna go through blood. I did leave the whole slide packet in here, so you guys could use some of it as a review because you've already covered it, but I'm gonna focus on what new material. All right. So there's learning objectives you can go in here. Some of them are going to pertain to material that Dr. Bush has covered or Dr. Ryman. So just heads up on that. Since cumulative final, I figured that would be helpful to just leave it in there for you guys, another little view of it, if you will. Okay. So primary function of blood, transportation, really, taking oxygen to our different tissues that need it for cellular respiration, and then taking the waste product CO2 towards the lungs so that we can exchange it out of our bodies. Okay. Um, Immune, you guys went through, and then buffering. Buffering allows us when we consume, acids or bases or alterations in the body with exertion, stuff like that, and we can maintain a pH level of 7.35 to 7.45 in the bloodstream. Okay, so we have that ability, and that's the bicarb buffer system, and that's what you're seeing here through this conversion using carbonic anhydrase. We can convert into carbonic acid or break it apart into hydrogen and bicarb and get rid of that hydrogen ion, through urine or breathing, for example. Characteristics, you guys can go through this. What's the composition of blood? Okay. Hematocrit, so that's just looking at the percentage of red blood cells. So when they spin the blood down, you get plasma separation, what's called the Buffy coat, and then erythrocytes, because of their density, they are at the bottom. And also, it's going to be different male to female, body size, all of that's going to affect it. Typically, males have higher rates because of higher muscle composition of the body. So they require more oxygen being delivered to tissue. Okay. As far as your plasma is, it's water for the most part, and then there are other things floating around in it, so like proteins, lipoproteins, okay, whatever we're transporting that we ate, for example, that's going to be there as well. As far as the protein structures, albumin is the greatest one. That's where a big part of our osmotic oncotic pressure is coming from, but it also is used for a transporter. So your lipoproteins, certain medications are bound to albumin and transported that way. Remember, albumin is produced by the liver. So if there is a liver disease, it's going to affect the ability or the functionality or the existence of albumin, we should say, to where osmotic oncotic pressure is decreased. And that's why we saw, in digestive, we talked about ascites, like that's edema because we've lost the production of albumin, and you're going to see it in other parts of the body as well. Okay. Globulin, so you guys learned about them like immunoglobulins or your antibodies, for example. And then fibrinogen, you guys learned about for clotting. Okay. So, like we mentioned, albumin made in the liver. If we lose it, edema. All right. And it's not the only driving force for osmotic pressure. Like, definitely all the other solute in your plasma is affecting that. It is just one of the greatest forces in it. That's all. Also, drink your water. This one's really good if you're looking to try something different. The Waterloo is really good, and Publix runs BOGO. Okay. Um, Anywho, you guys have gone through these cells, so run through them, refresher. All right. Bone marrow, we've talked about, the generation of these cells. This is for your review periods, okay? All of that. Um, your red blood cells, they live about 120 days, plus or minus a week, okay? They can't repair themselves. They don't have a nucleus anymore. They literally generate their hemoglobin, and part of their development, once they generate it, they barf out their nucleus to make more room. So over time, they start to break down as they pass through liver, spleen. White blood cells will actually like eat them up, break them down, and recycle the hemoglobin. that we've looked at as well. Erythropoiesis, you guys should be familiar with this. The kidneys, we just talked about, and renal are generating this, and that is what's stimulating bone marrow to produce your red blood cells. Okay. And really, it's just lack of oxygen, like we've talked about. That is what's going to stimulate it. Right? Um, the hemoglobin structure, so it's a four chain structure, four proteins in here, two alphas, two betas in the adult. In the child, it's alpha gamma, I think. It's a little different. Its affinity for oxygen is much higher, and you need that in the fetus and so that it can actually steal the oxygen off the mother's hemoglobin. So it wants that oxygen more and it yanks it off. Okay. The blood of the mother and the fetus do not mix. They pass near each other, vessels near each other, and then the oxygen leaches out. Okay. Um, Iron plays a role in this structure, okay? Plays a big role for us having the ability to bind oxygen. And then we have our normal ranges here. Okay, you don't need to memorize these ranges. If I'm going to give you a question, I would give you, the range or tell you it's abnormally high or low. Okay, I would generalize it. Inside the red blood cells, that's our buffer. And this plays a crucial role when you talk about like acid base, all of that control. We're missing in the middle here. I always forget to fix this. Carbonic acid. So refer to that original equation on the earlier slide. Okay. So red blood cells, as we break them down, we reuse stuff. And so we looked at this. This is, generation of bilirubin, how we get rid of it. So same thing, review this. Okay. Disorders. So with, these different disorders, you think like, a little too much red blood cells, not a big deal. Problem is with like polycythemia, your viscosity increases. If your viscosity increases, your chance of clotting increases. So not a good thing by any means. Okay. Um, there are different causations. So like I have bone marrow cancer, for example, like if the cells aren't functional, the body doesn't understand that. And so the response is, let's make more. It's not working. And so it starts overproducing. So sometimes, patients with certain bone cancers, they'll, pass out because the cells aren't functioning. They're not carrying oxygen properly, something like that. Or they'll develop sudden strokes or transient ischemic attacks. And that's how we can pick up on like something's going on here. So this is why it's important you always do blood work because you may not know you have a polycythemia due to some dysfunction until it's catastrophic. So the earlier we catch something, always better. High altitudes, we talked about this, like athletes going training up in like Colorado because of the low oxygen in the atmosphere, the body will respond after a couple weeks and start producing more red blood cells, increasing carrying capacity. So this is considered a secondary causation. So primary is like bone cancer. The root cause is that issue, whereas secondary, it's just due to something else that is triggering it. Okay. Um, and like I said, viscosity increase, that is our problem. Anemias, so this is a decrease in functionality, and there's all kinds of different causations of anemia. So it's just a handful, okay? So we have lower carrying capacity, so fatigue, lethargy, just weakness, tiredness, all of that plays in here. So first one I have here is hemorrhagic blood loss. So sudden blood loss, there's no carrying capacity, okay? Iron deficiency, we can't generate our hemoglobin structure. Hemolytic, this is where cells are lysing. So the red blood cells, like I mentioned, 120 days plus or minus a week. You get into diseases like thalassemia major. So there's beta thalassemia major, and that beta chain is dysfunctional. And so it increases fragility in the cell membrane. And so their red blood cells lyse or undergo hemolysis every 60 days. So they're at a severe anemia. They need blood transfusions. They cannot produce enough red blood cells in time, right? There's also like mechanical heart valves, for example. When the red blood cell comes through, it strikes it. It's such a rough surface, it lyses it. Okay. Um, the Pernicious anemia, we've mentioned before. So, this is where intrinsic factor is not being produced. It's an autoimmune disorder where that parietal cell is being attacked. The intrinsic factor production is gone, and you need intrinsic factor to bind vitamin B12 so that it's like the key for it to be absorbed. So, without intrinsic factor, we cannot absorb B12. Okay. Hemolytic anemia, we've talked about, aplastic anemia. So this can be idiopathic. It just happens. Their bone marrow gets wiped out. And so they can't produce cells. Their immune system is tanked as well. And so it's very dangerous disease. There are other causations of it, like, when we do like generalized chemo, some of the very older stuff could trigger that. There are some old like antibiotics that we don't use anymore, that could trigger aplastic anemia. But usually it's just idiopathic. It just happens, some type of autoimmune response. We don't know why. Sickle cell, the shape of the cell will, under like stress, will change. It'll go into that sickle form. It does not circulate properly. And it's not as functional. Um, Blood typing. So on the surface of our red blood cells, you have two protein structures. Okay. These protein markers are how we identify ourselves. So they're like antigens, okay, glycoproteins. And you can have different combinations. So you can have A and your blood type A, or you could have A and O, your blood type A. But if your partner is OO or AO or BO, what can happen is they can pass the O on because you pass on one allele. They pass the O on, and you pass the O on, and you can have a child that's O blood type, even though neither of you are O blood type. Okay. So AA or AO, BB or BO. Okay, if you didn't shower today, that joke will never get old. All right. Just never get old. Either of those combinations. Then you can have a B blood type. Okay. O in reality, true O blood type is OO. There's actually no structure there. There is no antigen. And so it's absent. But in medicine, we have to document, right? We have to say like we checked, it is there. Because if you don't, it's like you never did it. So that's why we put a marker there, even though there's no marker on the surface of that red blood cell, there is nothing. And that's why we can give it to everyone, okay? Especially when we talk about negative blood types. All right. Where is Can I draw on here? Let's see. Are you gonna draw? Oh, okay. Let's see if that works. So the reason I talk about this is if you do a Punnett square, right? So let's say you are a O and your partner is B O. Tell him to shower. Your I know. It never gets old. I know. So your offspring potentially could have AB blood type. They could have just B blood type is how it's going to exhibit itself. Even though it's BO, it would just be B. Okay. They could have A blood type because that O is technically not there. They don't have a marker. Or they could have O blood type. So it's pretty wild when you think about like that comparison or that potential there. Right. All right. So, how do you clear this? Oh no. Clear. Clear all drawings. There we go. Okay, back in business. So, agglutinogens or antigens on the surface. That's the other name for it, all right? So, whenever we give blood or we're testing for blood, we're trying to look at what's on the surface of the blood, what markers are there, and then are there going to be antibodies against it? So if I have B blood type, all right, I could be BB or BO. I showered today, so we're going BB. All right. On the surface of mine are B. In my bloodstream, I'm going to make antibodies against A. I cannot accept any blood that has A because if that comes into my bloodstream, the antibody and antigen will combine and it'll clump. And if it clumps, it occludes vessels. If it occludes vessels, there's no oxygenation to tissue. Okay. So that's ABO mismatch. That's really where we discovered a lot of this immunity was stemming from that. We give blood to people and all of a sudden it's clotting and problems, and some you don't. That's how we kind of a lot of this discovery, the antigen antibody clumping, a lot of it stems from there. So if I'm going to receive blood, you're always concerned about my ability to produce antibodies. I don't care about, potential white blood cells that are coming from the donor because in reality, when you spin it down and how long they live, by the time you get it, they're gone. If there's some antibodies in there, it's irrelevant. It's minute. Okay. What I'm concerned about is on the surface of the red blood cells I'm getting. That's what matters because me, I have an active immune system. I am going to produce white blood cells that are going to target those and attack them. Okay. That's what you're concerned about. So when they test blood to figure out what kind of blood you have, for example, they put your blood in a little well and then they drop antibodies on it. If it clumps, we know on the surface of your cell is that antigen. That means you have that blood type. Okay, so for example, here they put anti-A serum on there and it clumped. Well, that means they have an A antigen. They put B, they have a B antigen because it clumped. Here, this is strictly type A blooded. Only the A antigen clumped. They put B, no clumping. Okay, and so on. O, there's nothing on the surface. So they put A, no clumping. They put B, no clumping. Okay, nothing to target. So that's my point. We look at donor's red blood cells, what's on the surface, and then my antibody production. Okay. To top it off, so that's ABO, we have Rh factor or D antigen. If you are a positive blood type, you have another marker on the surface of your red blood cells, the Rh or D antigen. If you're negative, you don't have it. It's absent. Okay. Same thing as like O. What's interesting with this is so they discovered in rhesus monkeys. That's why it's RH. It's kind of fun fact. What's interesting with this is if you're a negative blood type, okay, let's say you're A negative, you produce B antibodies from beginning of time. Somehow, and I know Dr. Ryman and I talked about this at some point. We're like, how the heck does that happen? How do we have the genetic knowledge to produce antibodies to something we've never been exposed to? Somehow our system does that. We don't know how or why, but it's pretty wild if you think about it. It's coded in there. It's almost like it's part of innate, but it is stimulating adaptive to produce antibodies. It's weird, right? So you would think if you're a negative blood type, I would produce for the positive. You don't until exposure. It's some weird phenomena. So if you are an A negative blood type, you have B antibodies, and that's it. But it say someone gave you a positive blood type, you were exposed somehow. You then would produce antibodies to the positive blood type. Okay. So what's interesting is when you talk about pregnancy. If your mom is a negative blood type, your dad is a positive blood type, and then you, as the fetus, end up getting that positive trait, that can be a problem. So what happens is if the mom produces antibodies to the positive, it can cross the placenta and attack the fetus and destroy their blood. They will produce IgG that'll cross and attack. Okay. So typically what they would say, first child, not a problem. The problem is, like as we're delivering, whatever, maybe some baby's blood, umbilical cord, something somewhere gets ruptured, mom gets exposed. She produces now the positive blood type. The next child, it will attack. So typically they're stillborn or they die very early on, and that's erythroblastosis fatalis. That is the term. Okay. So it's interesting. Like, we typically don't see this too much anymore, but it's starting to rear its head. Why is it starting to rear its head? Is people are opting not to do traditional maternal care. And so you're getting these situations where they are unaware that they are a negative blood type, fetus is a positive, and it's going to be attacked. We can prevent this through a medication called RhoGAM. So we give RhoGAM to the mother, and it will stop the production of the antibodies. Okay. So there was, if you guys watch 90 Day Fiance, I mean, it's a train wreck of a show. If you want some horrible entertainment, watch 90 Day Fiance on TLC. Anywho, a few years back, there was a couple on there, and she had made a statement about she had been pregnant before and she had a blood disease and it attacked the baby and killed the baby. It's erythroblastosis fetalis. And she opted to still deliver the next child at home using a doula. And that's fine if you want to use a doula. They're allowed in hospitals. You're much better off having some proper care around you. And was like doing a water birth, and it's like, okay, so now we're sitting in feces, like the baby's in feces. That's how they get meningitis. Not recommended. You can do water births at the hospital. They provide that because they want you to be under proper supervision, proper care. Things go bad fast. All right. You get fetal heart distress. Like there's all kinds of issues that can happen in the moment. So if you ever want to have, a child and you decide you want to have like a doula or something, midwife, they have them in the hospital. You can go with them to the hospital. Uh, have your baby at the hospital. Okay. All right. White blood cells, you guys have gone through, so you should be comfortable with all of this. Just in here for review for you guys as well. Okay. Talked about anaphylaxis already. Um, White blood cells. So abnormalities in white blood cells, if they're low, you cannot fight infection. There's also all kinds of causations for leukopenia, leukocytosis too much. A lot of times, if you have active infection, you're going to upregulate the production. There's clonal expansion, all of that. That's going to increase it. Dehydration and really like overhydration can always alter blood work because it's always measurements over volume of fluid. And so it can alter the concentration. Okay. Um, Leukemias, so there's different types. There's the myeloid leukemias and then lymphoid leukemias. So there is acute and chronic of each version. So there's four that you talk about. But since the cells are not functioning properly, we have an overproduction typically, and we can have abnormalities as far as being able to fight, illness since they're not functioning properly. Um, you're not producing platelets appropriately, so that's where like hemorrhage comes into play. All of those can be factors. Okay. Platelets are not cells, they're fragments of the megakaryocyte, okay, and blood clotting is their job. You guys should have gone through that already with Dr. Bush, but it's there for you, okay? Platelet counts, if they're altered, once again, bleeding, that's going to be the biggest issue. Thrombocytopenia, so if there's too little, typically it's due to a deficiency or we're causing it through like chemotherapy or there's some type of cancer, something along those lines. Okay. Clotting, you guys went through this, but here it is for a refresher. Remember, this is like a cascade. So you have prothrombin, which is made by the liver. It's floating around. And then we release prothrombinase that causes us to have thrombin. Thrombin now will activate fibrinogen, which is floating around, and convert it to fibrin. That's the clotting factor. Okay. Now, how do we break up the clot? This you guys did not cover. So we need to reverse this cascade. Basically, what happens is we have a zymogen release, plasminogen, or sorry, it's floating around, and we release TPA, tissue plasminogen activator. TPA causes it to convert into plasmin. Plasmin will cause fibrin to convert into fibrinogen. It's now deactivated. So that's how we break down clots. We use TPA as a medication in the hospital. Um, they'll use it bedside during a coding situation. So when people have like pulmonary embolisms or saddle emboli, like stroke clots, this is a life-saving drug. So if someone is having a stroke, I think you get 3.5 hours, if I remember correctly, to get them TPA before there's permanent damage, or you're reducing the damage at least. How about that? Um, I know my wife had told me at some point TPA it's about $30,000 per dose. It's rather pricey, but life-saving drug. I mean, the pharmaceutical company wants them to use it to the point where if they compound it, bet like if they're about to use it for a patient, they decide not to use it and they've already mixed it, they compounded it, they send it back to the manufacturer, they'll send them a brand new one. They would rather you use it, save a person's life. That's the end of it. Okay. What's the downside to using TPA? Think about that for a second. Now I'm going to ruin it for you. They bleed out. Okay. Bleeding risk is through the roof. So if a patient has a stroke, we have to image and make sure it's not a hemorrhagic stroke. They haven't blown a vessel. Because if you give this, it's just going to promote the bleeding way more. Okay. Um, but yeah, if it's a clot, we can use it. All right. Other drugs that work on clotting. So anticoagulation is basically we either stop the clotting cascade or we stop platelets from sticking. We interrupt it somehow. So heparin is a quick acting, non-long acting. It blocks thrombin. Okay, so usually we use this, when you're starting to get patients on a long like treatment protocol like warfarin or I forget the other ones now. Hmm. It'll come to me. Anywho, other anticoagulants that take a longer time to like load up in their system, you would use heparin to bridge them, for example. Before surgery, we'll use heparin. And people don't think about that, but if I cut your leg open, that is a wound. It is going to trigger the clotting cascade. It's going to trigger it in all parts of the body. And that's why like patients are very high risk for developing clots post-surgery. That's why post-surgery they want to get you up and moving as quickly as possible because stasis of blood causes clotting. Okay. So we can use heparin to reduce this risk. Um, Vitamin K antagonist, that's warfarin, or Coumadin. So that's what they use as rat poison. It makes them bleed out profusely. So controlling this is tough. You got to have a really targeted range of drug. They have to have blood work constantly. So some of these newer ones that have come out are you don't have to have blood work done all the time. They're much more effective. And they're like a pill they take daily. It's so easy. Okay. And then TPA we talked about. All right, hemophilia. So there, hemophilia, also called Christmas disease, that's like an older term. There's a couple different types or levels of hemophilia as well. But basically, something's wrong with the clotting factors, and so they are high risk of bleeding. It's X-linked, sex-linked, and so males have a 50% chance higher with X-linked disorders of having them, since the male has one X. Okay, so it's passed from the mother because the mother or the females have two X's and they use bar bodies, they shut one down. So there is reduced chance of them having it. I had a student that had hemophilia, and he had already had, I think it was a shoulder replacement because they bleed into the joints and it destroys the joints, and his knee was due. And he didn't have it super severe, just to put it in perspective. Okay. Hematomas, so this is blood leaving the vessel, trapped in the tissue, and there's all kinds of causations, trauma. As we get older, vessels are weaker, overuse of Anticoagulants can trigger hematomas, so that's why they have to be monitored. Okay. Thrombosis, this is a clot. So it is trapped in a vessel, and when it breaks free and it starts traveling, that's an embolus. Okay. So emboli, they're traveling around, and what happens is if you think about like a DVT, a deep vein thrombosis in your leg, the vessel is small. When it breaks free, as it climbs up your leg, the vessels are getting bigger and bigger and bigger. We enter inferior vena cava, we go to the heart, we go through the heart and we're going to the lungs, big vessel, getting smaller, smaller, smaller. We get into capillaries in the lungs, they get stuck. Okay. Uh, Typically, they're on the venous side, but things like AFib can develop thrombosis in the heart on the systemic arterial side, and they can go to the brain. They can end up with strokes. They can actually go down the aorta to the abdomen. They can develop basically a stroke of the trans or ischemia of the transverse colon, and that can die as well. So it just depends. So that's why they need treatment. Right? And that's it. All right. I hope you guys enjoy it and enjoy your break. And I will get questions up for you guys. I will post that.